Let's just dive right into this. Welcome to This Explainer. Today, we're going to unravel a bit of a medical mystery, and it's one that's been hiding in plain sight. We're going to take a really close look at one of the most common, yet honestly, probably the most misunderstood phrases in all of modern medicine. If you're a clinician, you've definitely said it. And if you're a patient, it is the exact phrase you are holding your breath to hear. But, as we'll see today, taking this phrase at absolute face value, well, it might actually be blinding us to the true story of a patient's health.
And here it is. Your labs look normal. Healthcare providers deliver these 4 words every single day, right? And patients desperately want to hear them, assuming it means, they're totally in the clear. It brings this huge immediate sigh of relief. But today, I want to gently challenge the assumption that this very common phrase automatically rules out significant chronic illness.
Because it brings up a really fascinating core question. Does normal actually mean healthy? Does it mean there's an absolute absence of disease? Or does it mean something entirely different, something purely mathematical? These are fundamentally different questions, and confusing them can literally lead to a decade of missed opportunities for patients' healing.
So to really understand this, we have to define what normal actually means in the context of a lab report. A normal laboratory value is simply a result falling within a statistical reference interval established from a large population. It's a bell curve. It's just statistics. It is not necessarily this definitive declaration of an individual's personal wellness. Now, don't get me wrong, the tests are incredibly valuable, absolutely crucial, but they always have to be interpreted in the context of the actual human beings sitting right there in the exam room.
Section 1. A decade in the dark.
Let's look at a real-life case study to see how this plays out. This is about a previously completely healthy healthcare provider who actually became the patient. Over 10 years, they experienced this devastating cascading parade of symptoms. It started in year 1 with chronic fatigue and cognitive dysfunction, plus some strange retroorbital pressure. By year 4, it had evolved into migratory tendon and joint pain, severe exercise intolerance, and all these new food sensitivities. Fast forward to year 7, and recurrent urinary symptoms and inflammatory flares were affecting nearly every single aspect of their life. By year 10, they had undergone massive conventional medical evaluation. We're talking neurologists, rheumatologists, dermatologists, infectious disease specialists, gastroenterologists, the whole shebang. And throughout all of this, inflammatory markers were repeatedly normal. Autoimmune testing was totally unrevealing. Chemistry panels were largely right there within the reference ranges.
And here is the really crucial point. Each specialist evaluated the organ system they knew best. Every single laboratory panel successfully answered the highly specific question it was designed to answer. But none of them answered the big, overarching question, why on earth was this previously healthy person still chronically sick? The testing wasn't wrong. The problem was that the clinicians were just asking the wrong questions of the data.
Section 2. The paradigm shift. Snapshot versus story.
This brings us to a huge, critical shift in how we need to view laboratory data. We have the old way of thinking, right? Viewing a single lab test as an isolated binary pass or fail metric. Is the white blood cell count normal today? Is the CRP elevated right now? Each answer is viewed totally independently, almost like a snapshot taken on one specific day. But this new methodology, it requires us to look at 10 years of lab results, not as individual snapshots, but as a continuous physiological story.
We have to consciously shift the question from, is this abnormal today, to what has changed over time? You see, chronic illness rarely just pops up entirely independently in a vacuum. It develops through complex, long-term interactions between the immune system, the nervous system, the endocrine system, the gut microbiome, environmental exposures, genetics. It's a huge web. Sometimes the individual laboratory values aren't all that remarkable on their own, but the pattern they form over time, that is absolutely remarkable. Context overranges every time.
Section 3. Pattern recognition. Clues of persistent stress.
Okay, let's put this into practice as a guide for clinicians and see how longitudinal pattern recognition actually works. Here's a retrospective look at more than a decade of Quest laboratory data from our specific case study. When reviewed chronologically, these subtle findings that had never been connected before suddenly began to emerge. Notice these markers: intermittent leukopenia, persistently low monocyte counts, the presence of macrocytosis, a low normal alkaline phosphatase, and occasional fasting hyperglycemia despite the patient living a very healthy lifestyle. Now let me be crystal clear here. None of these findings on a random Tuesday were diagnostic on their own. None of them justified dropping a specific disease code on the patient, but as a pattern, they were screaming that something was fundamentally wrong. And it's incredibly important to note,
as our source material impartially reminds us that these findings are not specific for any one single thing, like mold exposure, for instance. They can occur in so many different conditions: nutritional deficiencies, medication side effects, endocrine disorders, liver disease, or hematologic disorders. They always require a broad differential diagnosis and must be interpreted within the proper context of the patient.
But this quote from the patient, it perfectly captures the essence of why pattern recognition matters so much. They said, "My physiology was changing, not enough to trigger alarm, but enough to suggest that my body was under persistent stress." Patients don't experience illness according to rigid statistical reference intervals. They experience subtle but very real changes in their underlying physiology. And that is exactly what we are looking for in the longitudinal data.
Section 4. Diagnosis comes from correlation.
So how do we build an actionable framework out of this? Well, the answer is that a true diagnosis doesn't just come from a single piece of paper, it comes from correlation. It's about integrating objective laboratory data with the patient's entire history. Let's walk through these steps. Step 1, a deep, thorough clinical history. Step 2, a thorough exposure history. This includes occupational and environmental factors. Step 3, the physical examination. Step 4, objective laboratory findings and imaging when appropriate. When these independent, distinct lines of evidence all start pointing in the exact same direction, that is when our diagnostic confidence dramatically increases.
Now, I want to make sure we're on the same page here. The goal of this explainer is absolutely not to suggest replacing conventional medicine. Conventional laboratory testing remains absolutely essential. It rules out serious acute diseases, it identifies conditions that require immediate life-saving treatment, but crucially, its third role is that it should spark intense clinical curiosity when a patient is significantly impaired, yet the routine testing remains totally unrevealing. We really have to resist the temptation to just conclude that nothing is wrong purely because the standard panel is all green. Instead, when the labs are normal but the patient is clearly sick, we have to expand the investigation. In our case study, the story only finally became clear when the provider looked well beyond conventional testing. They ordered environmental assessments which actually identified hidden water damage. Targeted sampling documented fungal contamination, and biologic testing demonstrated evidence of mycotoxin exposure. Again, these didn't definitively prove mold was the sole cause, but they were the missing puzzle pieces that perfectly fit the clinical and exposure history.
And this brings us to our most vital takeaway today. If we focus exclusively on the numbers, we risk entirely overlooking the living, breathing person behind those numbers. Medicine is at its absolute best when it combines objective science with thoughtful, deeply engaged clinical reasoning. The laboratory provides the data, the patient provides the context, and it is the clinician's job to put those two pieces together.
Because sometimes the answer just isn't hiding in another routine blood test. Sometimes it's hiding in the pattern that emerges only when we step back, look at the timeline, and see the whole narrative. Which leaves us with this final, rather provocative thought. What if the most important diagnosis isn't hiding in the patient's body at all, but in the building they live in? Just something to think about the next time you review a normal lab result. Thanks for joining me on this explainer, and I'll catch you next time.